Hi everyone, it's Tachapong Ngarmukos from Bangkok, Thailand. I'm tasked to talk about syncope in athletes today. Let me share my screen. Okay, all right. Syncope in athletes. So let me tell you about this patient who I just get called while I was preparing for this talk. So there's a 17-year-old man, basketball player, uh, who passed out after he was switching the player. So we came back, sit down. He was not complaining of anything, and then he sat down and collapsed in front of his colleague. He spontaneously gained his conscious, felt a little tired, pale, and sweaty, and his physical exam is, unremarkable at best, or maybe we are just missing something. So anyway, syncopating athletes, they found out about 6% of the patient, of an athlete uh, had syncope in the past 5 years. So most of the time it's benign cause, and uh, only small number of patient actually has heart problems. Simple classification of these type of syncope in athletes are: number one, uh, unrelated to exercise, so they just pass out, nothing to do with exercise. That's probably the most common one. And then there's post exertional syncope, that way they just pass out right after they finish their exercise. And then there's exertional syncope. Let's look at this. So here, this is the number from Kowecki. About 7,500 patients. There were 6% with syncope, and again, mostly they were syncope not related to exercise, mostly vasovagal, and about 10% or so were situational syncope. Post-exercise at about 10%, and these were, post-exertional postural hypertension in pretty much all cases. Exertional syncope, though, the 16% of the patient has hypertrophic cardiomyopathy, RVOT, tachycardia in 16%, and then the rest are still exercise-induced neurally mediated syncope. Now, whether they post-exertional or non-exertional, both has similar uh, prognosis in terms of survival of syncope again. Uh, Again, syncope unrelated to exercise, the most common presentation, and again, largely were vasovagal situational dehydration and reducing intravascular volume induce kind of orthostatic hypertension and cause more of these events. Again, post-exertional also, it's due to sudden stop of exercise and decrease in venous return from the muscle not pumping, and then started the increased cardio depressive reflex, and then the patient passed out, just like vasovagal or any other type. Again, dehydration, reduction in plasma volume also usually trigger this, and usually happens while patient's still standing, immediate post exercise. These are less concerning than when you have exertional syncope. So when you have exertional syncope during exercise, so it's a bit of a concern whether it's related to structural heart disease, which means sudden cardiac death may follow. Hypertrophic cardiomyopathy, abnormal coronary artery origin, ARVD, channelopathies, myocarditis. These are, are the culprit of these type of syncope, non-compaction and congenital things. So from this, evaluating athletes with syncope, a comprehensive history is very important. You need to take good history, including sudden cardiac death in families. The circumstance, the timeline, what they were doing before, drinking, not sleeping, and those type of things. And again, if they pass out, especially during exercise, they should be taken out of the exercise program until they checked out that they're okay. Red flag symptoms are chest pain, palpitation, shortness of breath. Keep in mind that a lot of athletes will kind of downplay their symptoms or history, so they're not prohibited from doing the things that they like. Again, family history, social history, drugs. In Thailand, we would have the weed as well. Okay. Oops. Yeah. So baseline testing would be ECG, echo, stress tests. Keep in mind that for stress tests, a long distance runner or basketball player you have to adjust the stress test according to what they do. Implantable loop recorder, nowadays mobile device, EP study and ablation. These should all be considered, not mandatory. These were the guidelines from these review article, which I think it's good for recommendation, although I don't completely agree with it. So you have athlete with complication, you're checking for the timing of syncope, all the program, post-syncopal event, family history of sudden death. If it's unrelated to exercise, you check to see what if it's vasovagal or situational, and then you treat them accordingly out of these scope of these talk today. If it's post-exertional, again, usually orthostatic volume depletion. If it's syncopal during syncope during exercise, then you look for all these structural heart diseases you can see here. And then you proceed to second tier testing, ECG, echo, exercise, event monitoring, and then third tier, which is cardiac MRI, CT, EP study, and angiogram and genetic testing. Again, this one. Do I completely agree with this? I don't know. I'm not too sure about the second tier and the third tier. So who cares about syncope? Anyone remembers Euro 2020, the UEFA football thing, which was the event that was held during COVID? Well, if you don't, let me remind you. Christian Eriksen had cardiac arrest during the football game. Luckily, he was resuscitated, and he was still going out from the field, and he was fine afterwards with the defibrillator. Sudden cardiac death is probably what we're concerned. It's ranging from 1 in a million to 1 in 23,000 each year, and sometime in like basketball player, in subgroup of basketball player, people with skin color, 1 in 3,000 potentially. So in high school it's 1 in 80,000, and in college it's 1 in 50,000. So you could see that as the sports increase, the intensity, the chance of sudden cardiac death kind of goes up. The again, female are kind of protected or less risky than male. And again, basketball. Keep in mind that this happened in military personnel as well, at even a higher risk compared to general population or even athletes with more stress, I presume. Again, these are the causes of people having sudden death when they are younger than 35. Primarily electrical disease without any specific identification, idiopathic left ventricular hypertrophy, anomalous coronary origins, HTM, ARVC, myocarditis, electrical disorder of sort. And then, commonly when it's more than 35, then it becomes coronary artery disease. idiopathic LVH. The other things are similar to the less than 35. Exercise is good in promoting cardiac injuries. Yeah, so it's bad for the heart. So exercise may accelerate inherited cardiomyopathy. Exercise itself could be causing arrhythmogenic remodeling. I'll show you later. And certainly, if it may exacerbate cardiac damage due to, people who have intercurrent illnesses. So these are patients with arrhythmogenic right ventricular dysplasia. Sports activity actually could increase phenotypic expression, disease progression, and it could trigger arrhythmia. So keep in mind. Now, there's also exercise-induced cardiomyopathy, where it's kind of similar to exercise like ARVC. So exercise-induced arrhythmogenic right ventricular cardiomyopathy. Now, there's healthy athlete's heart with symmetrical dilated four chambers, with normal to low normal ventricular function, and then there's good augmentation with exercise. There's minimal mechanical dispersion, and then no arrhythmia. Now, there's few forms of exercise-induced arrhythmogenic cardiomyopathy. Mostly involve the RV. Getting bigger, more dilated, causing RV arrhythmia. There's epicardial scar, outflow tract arrhythmia, which may not be that significant. And then there could be some people who have LV involvement as well. So they all potentially could cause arrhythmia, certainly the concurrent diseases. Now, people with athlete's heart, you have to look at whether they really have athlete's heart or hypertrophic cardiomyopathy. You look at the family history of HCM. There's no diffuse T wave inversion. You check the MRI, there's no scar. The LV hypertrophy is symmetrical and evenly distributes. Echo, we have big heart with enlarged LV and diastolic dimension. Again, symmetrical hypertrophy, normal diastolic function, at regress after deconditioning. And again, you can check the genetics for hypertrophic myopathy. What can we do? Screening? There's a guideline on it. There's only one paper that showed that doing screening actually decreased the risk of death in athletes down to almost the normal population level from Italy. But that's the only study though. And what to do, what to screen? You can take history, you can take physical exam, or you can add EKG. You can see that adding EKG right here, down here, you increase the sensitivity of the screening significantly. So, a lot of people, the European always recommend that get an EKG with screening tests. There's pros and cons with screening tests. Pros, you can identify people at risk of having sudden death. You can understand the impact of sports on structural heart. And if testing is normal, then the risk is very low, not zero. Cons, you find something that has no clinical consequence, but cause unnecessary sports restriction, the cost of it, the psychological impact, the insurance, false reassurance. They could still die, even if you reassure them. There's a good number of false negative as well. EKG findings. These are things that do not require further evaluation: sinus bradycardia, sinus arrhythmia, ectopic echo-rhythm, junctional rhythm, first degree AV block, second degree type 1 AV block, incomplete right bundle branch block, just LVH on voltage criteria, early repolarization, and a dome ST elevation in V1 to V4 in African Black athletes. The other things you could see here, they're abnormal, which once you see it, you we'll figure out that these needs further evaluation. I'm gonna skip that. And again, this is like screening. There's pros and cons about it, so I'm gonna skip that. You know what the society recommend, the International Sports Society? Let me show you. You know, the issue is that these are richer people, and they're more higher risk at stake. So let's see. So you know, most people recommend physical exam and uh, history, and then there's almost everyone recommend 12-lead ECG. Some recommend echocardiogram, mostly the European ones. The estimate cost per each diagnosis. So in this group, the 20,000 young athletes, 7 to 18 years old, they did pre-participation screening, history, physical exam, EKG, and a stress test. You know, they found congenital heart disease, a channelopathy, cardiomyopathy, LV scar, and in 0.3% disease that at risk of sudden death. And they found as they repeat, they found more kids that having problems. They have one resuscitated cardiac arrest. So the costs were 73,000 euros for one diagnosis. Well, in summary, this is my EP syncope algorithm, which is also used for people who have who is athletes who passed out. History of syncope, physical exam, orthostatic blood pressure measurement. I always check EKG and echo regardless. This is where I disagree with the recommended algorithm before. Everybody gets EKG and echo. If you make diagnosis, fine, you treat them. If you don't, and to see if there's abnormal EKG or if ejection fraction less than 40, I guess the athlete should probably go up to like normal 55, 60. Then in that case, you consult an EPO cardiologist. If not, you do. So if their hearts are normal, you can do a tilt test and see how they do. And then if it's negative, then you do prolonged ECG monitoring. Nowadays, you could do, implantable loop recorder. You could do prolonged external loop recorder. There's many available nowadays. You can use those watch and things. And then if it's positive, then you treat whatever you find. Again, so this was the kids. This was his EKG. Looked like septal hypertrophy there with diffuse T wave inversion. We didn't find family history of sudden death. And this was his echo. You can see this. Looks like there's a septal hypertrophy, but it kind of looked a little bit diffuse. We on the workup on finding out what he has. So again, thank you very much for listening. I hope it's quite helpful on syncope in athletes. Thank you very much, everyone. Have a good day. Bye.